We already kind of have a package now of the ankle, okay? But what's going on here with rotation? He definitely had some unique AI symptoms. So when we scoured the hip on the left, the same side that has the knee, didn't have that groin type of underwear line pain, but it was more lateral. I'm like, okay, well, that doesn't mean it's not something at the joint. And significant external rotation asymmetry. Now, that doesn't make him a bad person. But now, when we have complaints of things that maybe I didn't mention earlier, because they were kind of like wishy-washy and subjective. Yeah, I don't feel like I can activate, like when I'm on my left foot or when I get on my left side in golf, like I just don't feel strong. Well, look, your quad is a piece of linguine compared to the other side. But is it more than just strength? Well, now when you see this kind of significant asymmetry, right versus left, and it makes sense to everything else that you're seeing, I think we need to look a little bit deeper. So no pain, definite stiffness, but definite difference. I mean, like probably 50% limited. Maybe the right side was around 40, 45. This side was maximum 20, in between 20 and 25. It wasn't even 25. Again, using my very keen oculometer for all of this. So, okay, what are we going to do? Well, Faber's test on that side, painful in the same spot, okay? Interesting. Did we look at other things? Should we mobilize the hips? It's still very, very weird. So in those types of situations, especially since we're not seeing exactly everything, just keep looking. Knee rotation, no problem. So then we get prone, and then we're going to look at spinal rotation, right versus left, with the lumbar unlock. So that means your legs are long. You're kind of in this sphinx position. And then we saw the asymmetry left versus right, but then passive, he had nothing. Okay, so do I really think it's the ball and socket? I'm not sure yet, but I'm thinking it's more north, because I don't know that the ball and socket can create a motor skill deficiency of spinal rotation. I'll say that again. I don't know, I don't think, I'm taking a position, I don't think in this case that an issue at the ball and socket that has trouble externally rotating, and I also see a full passive spinal rotation to the left, the same side, but not active. I'm going SI. We got to look at the SI anyway, anytime you have these rotation issues, but that's why. So now, do I have more evidence before I start to dig in? Because I'm not good at the SI evaluation. I'm okay at doing the treatment. So if we do the treatment and it's not streamlined, we just do one treatment and then retest. So we did get to that. But I also would look at spinal rotation with lumbar locked, where it's primarily thoracic. Saw the same thing with shoulder internal and shoulder external. Passive was perfect each time. So what do we look at? In my experience, remember the SI has kind of like 3 segments, 5 joints. That the S2 is the isthmus, S1 is the 2 isthmus is kind of where the PSIS line would be. S1 would be the lesser arm, and then S3 would be the greater arm. In my experience, you'll see greater arm lesions when you have a loss of external rotation. It's not the only one, but it's kind of like you skip steps without missing anything type of thing. So we treated the apex of the greater arm first, and bingo, okay? Pain gone on the hip, improved, not perfect, improved external rotation. Remember, my goal here is just to move the dial. So now, if we've changed the neuromuscular environment with some quick manual therapy, let's dive into that window. Let's steal as much as we can out of this house. And we were going to do that with external rotation mobilization, LDOA for hip external rotation, and then LDOA for apex of greater arm. Bingo. There's our whole approach, minus one thing, because I need to know that those primarily mobility type approaches are going to be successful and maintain. Well, how do I know? Stand up and rotate. Did it improve? So we're going to do glute max, which is like your figure 4 stretch. We're going to look at LDOA of the hip, which is this open half kneeling approach where you're trying to decoaptate and externally rotate. That's a very, very powerful tool. Does it move the dial? Yes, let's continue. Then we go to LDOA of the SI joint. And anytime you have any, at least the way I was taught and the way I would approach these things, if you think there's an SI problem, you gotta look at 5-1. And so in this case, we didn't treat 5-1. Certainly could have. I could have dinged it. I could have blasted out the SI if I wanted to. Could have gone after glute medius. See, there's no wrong way. Just get up and twist better. Just do a Faber's that doesn't hurt. Scour the hip where it doesn't hurt. That's the money. It doesn't matter how you get there. It just matters that we can all agree upon, did this thing do something better? And it might not even be for what you thought or how you got taught that method. As long as it happened, then you get into training. And that's where we need this individual to go. But in my experience, when we do the LDOA for the SI, we're going to do both sides always, even though we think this is on the left side. So we're going to do LDOA for apex of the greater arm on the left. Then we do 5-1. So you always kind of go from, you bounce back and forth, ricochet rabbit, from the SI LDOA back to 5-1, which most people think LDOA is like this exercise that you do with your legs up. It's like, in theory, you could do LDOA for every joint in the body. I don't know that there is one for every joint in the body, but there's something, even though they're not all called LDOA. Now, what's our game plan? Could he twist? Yes. Could he twist? So again, I don't expect this to stay, but we are going to follow that up with segmental rolling, using the lower extremity. And then we just see how do we know? His backward bend was way bigger. Hey, just get up and twist this way. And until you're, can twist that way easily, I expect that to be a short-ish period of time, then we stick with this plan. Okay, so there's that package. There's the calf stretching, rolling, if you're going to get a massage, have them beat up your calf and your plantar fascia. So there's that package. And then the third package is the quad. I think the knee is relatively healthy. I don't think the knee is a big deal. If that pebble, if that loose body is not resorbed, hey, man, sometimes we got to go in and pull the doorstop.